Today, today we are talking about anti-emetic and prokinetic as a clinical pharmacy. Let's define a nausea. Nausea is something unobservable, non-observable subject feeling of having urge to vomit. So the patient said, I'm sick, I have an urge to vomit, but no signs of vomiting appear, just it's a sense, non-observable sense. Even though there is face changes, there is a paleness in the face, there is drowsiness, there is unpleasant feeling in the patient, but there is no observable sign that you can say this person have an urge toward vomiting except his compliance and certain or some mild changes in his behavior, in his face expression, and other things. While the emesis is the process of projection of intestinal contact or stomach contact contents, outside the body through the mouth. It may be an acute emesis that occur within minutes and resolve within 24 hours, or may be delayed up to 2 to 3 days, or may be broke through emesis, which is an occurring after the prophylaxis with the anti-emetic treatment, so it is called also an intermittent emetic. So the person have a condition of remission and a condition of emesis. So this is called a breakthrough emesis and usually occurred with when the patients or the person use anti-emetic drug. Yeah. يعني the anti-emetic يصير عندي breakthrough يصير عندي waves of emesis, so it's called breakthrough emesis. Another point to check is the nausea and vomiting may be manifestation of certain disease or a response of certain disease. But in general, nausea and vomiting is a condition that occurs due to stimulation of the vomiting center that respond to input from. So the causes of nausea and vomiting, whatever the driving cause, it's come from the chemoreceptor trigger zone or disturbances of the vestibular system or an input from the CNS or cortical medulla or from the peripheries, such as irritation of the pharynx, larynx, GIT via the sensory nerve, such as smelling or engorgement of certain parts inside the pharynx or irritation in the GIT, such as using of high dose of non-steroidal. All of this and other things causes, and other causes may induce nausea and vomiting in persons. Also, we should get in some details about these spots. The chemoreceptor trigger zone stimulation. The fourth ventricle of the brain host is the vomiting center, which is called chemoreceptor trigger zone. It's called area postrema. When the chemoreceptor trigger zone is stimulated, vomiting may occur. Chemoreceptor trigger zone is physiologically outside the blood-brain barrier, and chemoreceptor trigger zone contain opioid receptor, D receptor, 5-hydroxytryptamine receptor, and substance P receptor. So these receptors is the target for the treatment of nausea and vomiting. way for the nausea and vomiting arised from chemoreceptor trigger zone, which is simplified with the symbol CTZ. But I prefer to get the whole name, chemoreceptor trigger zone, not the simplified characters. So we have a drug that induces nausea and vomiting. According to this, the opioid or the general anesthesia may induce nausea and vomiting. Also, chemicals and toxins and radiation may induce nausea and vomiting through substance P. Also, we have disturbances of the vestibular system or the GI irritation or myocardial infarction or renal or biliary stones for the renal due to severe pain, also for the biliary stones for the GIT irritation due to direct irritation of some certain drugs or reflexes. Also, disturbances of the vestibular system also may cause the motion sickness, may cause the what's called nausea and vomiting. The higher CNS systems, such as emotional factor, or some persons have reflex from smells, nauseating from smells or sight or certain conditions. So, the drug used for treatment of nausea or vomiting must pass through the phalanx. They deal with with the muscarinic receptor, with the dopaminic receptor, histamine receptor, serotonin, 5-hydroxytryptamine, and substance P or opioid. The etiology may vary from alcoholic drugs, infection, metabolic, acute abdomens such as appendicitis, colitis, pancreatitis, uremia, or gastroduodenal, such as peptic, gastric cancer, gastroparesis, or physiogenic factor, or CNS disturbances such as migraine, vestibular, an increase in intracranial pressure, and meningitis. All these factors may induce nausea and vomiting, and there is a personal variation between responses from person to person. Some persons get only nausea and others get nausea and vomiting, which different in severity from person to person. And this is called a personal variation of responses according to stimuli. According to pathophysiology of the nausea and vomiting, we can target our treatment approach. For the cancer chemotherapy or opioid, which may get the chemoreceptor trigger zone stimulated. So, dopamine D2 or 5-hydroxytryptamine 3 or opioid or substance P. This is the target for chemoreceptor trigger zone. While stimulation from the cerebral cortex causing the vomiting center in the middle to be stimulated, which is also getting the receptor of 5-hydroxytryptamine, substance P, which is the same, but here we have a histamine and muscarinic receptor. Also, we get the pharynx and GIT. We have 5-hydroxytryptamine and substance P. And also we have a vestibular system or the yeah, vestibular nuclear, we get a muscarinic and histaminic receptor. So we have various options for treatment according to the system stimulated. In vestibular, we have certain approach. In the vomiting center, we have another treatment strategy or approach. And for the chemoreceptor trigger zone, we have another approaches. The classification for the treatment, according to the past slide, we can deal with the nausea and vomiting through anticholinergics such as hyoscine and dicyclomine for treatment of vestibular system. Also, we have antihistamine, we have neuroleptics, which is a D2 receptor blocker, and we have 5-hydroxytryptamine antagonist. We have neurokinine, such as apiriptant and fosaprepitant. And we have a prokinetic, which is metoclopramide and domperidone.